Hello and welcome to the Bazooka. This is a series on my YouTube channel where we look at 10 Osce stations in one clinical course. This is season 2, episode 4, obstetrics and gynecology. If you haven't yet subscribed, hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos. Drop a like, drop a comment. While you're at it, share the link to this video and share the link to my YouTube channel. Grab your piece of paper, grab your pen, and let's go. So a warning in advance, there may be some graphical images as usual, and these are only meant for teaching purposes, so do not quote me out of context. So beginning with our station 1, study the picture and answer the following questions. Part A, identify the instrument above. Part B, what are the indications of this instrument? Part C, what are complications associated with its use? Part D, what is PAC? Opaque. Whatever that may stand for. Who knows? Anyways, you may pause the video at any time for you to actually answer the questions. So here comes the answer. So this is obviously a common syringe with the cannula in situ, used for manual vacuum aspiration, or you can call this a manual vacuum aspirator, and it's assembled. What are the indications of this instrument? So you can use it to evacuate retained products of conception. You can use it in the management of certain kinds of abortions, such as missed abortions, septic abortion, even incomplete abortions. You may also use it in the management of molar pregnancies. What are the complications associated with its use? So uterine perforation, infections, Asherman syndrome, or that may eventually lead to subfertility. Then PAC is post-abortal care. So often this is done to patients that have had some abortions that have gone place. And take note, I'm using abortion in the context of what we refer to in layman's language as a miscarriage, not one where someone actually induces it and decides to kill the fetus. So obviously you counsel the patient, you explain the cause and how they can be prevented. You tell the patient when to return, and if the bleeding doesn't stop, or in cases of them to actually having signs of infections such as a fever or an abnormal discharge, you also give them antibiotics and analgesia, offer them some family planning, tell them to avoid coitus for at least 2 weeks and avoid conceiving for at least 6 months. Also advise them to choose an effective contraceptive method. Moving on to station 2, another image labeled A and B. What is the most possible diagnoses? Identify A and B. Mention 2 risk factors associated with this condition. Mention 2 symptoms. List 2 investigations. How would you advise if she wants contraceptives? What are the complications? Take your time, pause the video if you may, but here comes the answer. So this is a molar pregnancy or hydatidiform mole. As we can see here, this honeycomb like appearance. Then or rather snowstorm appearance. Then you have A being the uterus, and then B, of course, these vesicles, which you can also even see on the ultrasound. Then 2 risk factors. The risk factors include maternal age extremity, so individuals below the age of 20, individuals above the age of 35, folate deficiency, prior molar pregnancy, race or geographic location. It's very common in the Philippines and the Taiwan. If you have a history of spontaneous abortions, people with blood group A who are impregnated by men with blood group O, coincidentally, that's also a risk factor. Then, of course, use of combined oral contraceptive pills. Then 2 other symptoms. So these type of hydatidiform moles or molar pregnancies tend to this tachycardia. Then list 2 investigations. You may perform an ultrasound where you will see a snowstorm appearance in a complete type of mole. You will see absent a fetal heart or fetal parts, and there is a honeycomb appearance of the placenta in cases of a partial mole. Your serum beta HCG is usually elevated, greater than 100,000 milli-international units per mil. And then you should also do a biopsy, or you send those vesicles for histopathology. You may also want to do a chest x-ray to rule out any mets. Then how would you advise if she wants contraceptives? So she should be on oral contraceptive pills for at least 1 year, to prevent any confusion from recurrent disease or normal pregnancy. Because when you treat these patients for molar pregnancies, you're normally supposed to monitor the beta HCG levels. And if a woman falls pregnant, you may not know if this is actually a recurrent disease or this rise in beta HCG is due to the pregnancy that is there. Then, of course, complications include recurrency or persistent of trophoblastic tissue, as well as malignant transformation with metastasis to distant organs. Then station 3, mention the indication of this drug. What is the mechanism of action of this drug? List advantages and disadvantages of this drug. So here's a drug depicted on the right of your screen. You may pause the video if you so wish. Here comes the answer. So this is a drug that's used for contraceptive or family planning. It's medroxyprogesterone acetate. So this is Depo-Provera. So the mechanism of action of this drug is that it's going to be causing thickening of the cervical mucus. It's also going to be causing alterations in the endometrial epithelium. It's also going to be causing alterations in the tubal motility, thereby preventing ovulation. Thereby preventing pregnancy. Then advantage is that it's long-acting. It has good compliancy. Of course, doesn't interfere with any sexual activities. Disadvantages of this is that you have a delay in return to fertility. There is a risk of abnormal uterine bleeding, and it does not protect individuals from sexually transmitted infections. And there is also an issue of weight gain. Station 4, what is the name of the test? What is the indication? Name 2 precautions before the test. Name 2 disadvantages for this test. So take your time. You may pause the video. I know you're doing very well currently on these Osce stations. And if you are enjoying these Osce stations, do not forget to drop a like and also drop a comment. It really helps with the YouTube algorithm. And also share the link, share the page, and keep subscribing on our road to 1,000 subscribers. We are very close to reach 1,000 subscribers, and I really can't wait to reach that mark. So here comes the answer. So this is a pap smear or papinoculo test. Then it's indicated in cervical cancer screening. And the 2 precautions is, number 1, you have to ensure that the woman is not menstruating. And the second thing is that the woman should not have intercourse prior to the investigation. There shouldn't be any douching. There shouldn't be any vaginal machines or medicines or any spermicides, creams, gels, or anything that should be inserted in the vagina prior to the pap smear. Then 2 disadvantages is that sometimes you may get the collection of cells that may not be adequate enough, or you may collect from a sample that doesn't have the pathology. Then the second disadvantage is that it actually needs a specialist to interpret the same results. Station 5, identify images A to D. So you may pause the video, take your time to look at this. I know you may not have seen this, or you may have overlooked this, or it may have been an oversight in your textbook, but trust me, they do ask these things. So here comes the answer. So A is, of course, a gynecoid type of pelvis. B is a platypaloid type of pelvis. C is an android pelvis. And D is an anthropoid pelvis. These are the different types of pelvis. I don't know what the plural of pelvis is. Please drop a comment in the section below what the plural of pelvis is. If it's pelvises or pelvi, I don't know. Drop a comment below. So just to give you some extra information about the different kinds of pelvis that you have in females. So you have a gynecoid type of pelvis, which is obviously the most common type of pelvis in female because it's generally considered to be a typical female pelvis. So it's going to have an overally round, shallow, and open shape, and it is thought to be the most favorable type of pelvis when you are performing a vaginal delivery. That's because it's wide, has an open shape, and it's going to be giving a lot of room for delivery of the baby. Now, when it comes to the android rather type of a pelvis, this is actually very similar to the male type of pelvis. So it's going to be much narrow as compared to the gynecoid pelvis, and it's shaped like a heart or a wedge. And because of the narrow shape of this pelvis, it makes it very difficult for the baby to actually maneuver or to actually move through the birth canal. And the baby might actually move much slower through the birth canal, and usually pregnant women with this type of pelvis require a C-section. Then an anthropoid type of pelvis is narrow and deep, and it has a similar shape to an upright egg or an oval. So because this type of pelvis is actually narrow and deep, it has this elongated shape that makes it a bit roomy from the front to the back, more roomy than the android pelvis, but it is still narrow as compared to the gynecoid pelvis, which is you could say the ideal type of pelvis for pregnant women. So some pregnant women that actually have this type of pelvis can still give birth vaginally, but their labor usually tends to last longer. Then with the last type of the platypaloid type of pelvis, it's also known as a flat pelvis. It's the least common type. It is wide and very shallow, and it's going to be resembling an egg or an oval lying on its side. So the shape of this type of pelvis actually makes vaginal delivery very difficult, and the baby may actually have troubles passing through the pelvic inlet. And of course, many pregnant women with this type of pelvis are going to be requiring C-section. So take your time to actually know this type of pelvis that you find in different women and how they look like, how to differentiate one from another. Moving on to station 6, which is a pathograph. Based on the pathograph, what was the diagnosis at T4? And what two things on the pathograph support that? What actions were taken at T equals 4 hours? What dose of oxytocin in milliunits per minute was she commenced on? What drugs are indicated by X at the 4 hours? What abnormalities are shown on the pathogram at T equals 10 hours? How should she be safely delivered? So I will zoom this a bit so that you can actually go through the pathograph here. So I think this should be adequate enough. So there you have your details of the patient. Here you have whatever is being plotted, and I will keep scrolling this a bit slowly down, a bit slowly down, a bit slowly down. Okay, so there's nothing that's recorded at the bottom there. Safe to say there's nothing recorded at the bottom, so we can just keep it here. So let's go to the question and then see. So based on the pathograph, what was the diagnosis at T equals 4, and what two things on the pathograph support that? So what's the diagnosis at T equals 4? You can pause the video now. And then we go back, what dose of oxytocin was she commenced on? Let's go back to that. So what dose was she commenced on? Then what abnormalities are shown on the pathograph at T equals 10? So T equals 10. What abnormalities are shown there? Then last but not least, how should she be delivered? Okay, so I have given you time to actually study this pathograph, and I presume you have written down the questions and actually paused the video. So let's zoom back out and let's see what the answers actually have to say. So let's actually go to this pathograph here. Okay, so I already explained how the pathograph was in season 1 of these videos. If you haven't yet watched season 1 of obstetrics and gynecology, and you by some chance find yourself to actually have stumbled on this video, I will leave a card at the end to check out the playlist on the pathograph or the video that contains the pathograph. So here you have your details of the patient. So surname A, forename B, and of course this patient is 19 years, zero parity, gravida 1. And then, of course, at 39 weeks. So remember that the pathograph is often opened at 4 centimeter dilatation. That's why we open the pathograph. And each of these large bars is going to be indicating an hour. The smaller divisions are going to be indicating 30 minutes. So you have this pathograph being open when this woman is 4 centimeter dilated. So 4 hours later, okay, we look at the dilatation. It's only moved from 4 to 5. So it's moving towards the action line. It hasn't yet crossed the action line. It's on the left of the action line. So once it crosses the action line, that means that you should do something. So we're looking at here at t equals 4. So already there's going to be a little cervical dilatation. We look at the descent that is present here. So this child was a 3, descent of 3, but 4 hours later the descent is pretty much the same, so the child hasn't moved any lower. So this child has a poor this mother has poor cervical dilatation and the child has poor descent. So obviously that is going to be a poor progression in the first stage of labor. Then what actions were taken at t equals 4 hours? So if we come here at t equals 4 hours, we can see that here there's artificial rupture of membranes. So they ruptured the membranes. So when you do a VE and you realize that the membranes aren't really ruptured, you can artificially rupture the membrane. It sometimes increases the cervical dilatation or hastens the cervical dilatation. So the ARM simply just stands for artificial rupture of membrane. And what was noted is that the amniotic fluid was clear at this point. So they ruptured the membrane. In addition to this, they gave augmentation using oxytocin. So oxytocin was given. And of course, an analgesia was given here, which is this drug, and some IV fluids were given to this woman. Then what dose of oxytocin in milli-international units was given? So here it's recorded that this woman is giving 15 drops per minute of 5 international units. So 15 drops per minute of 5 international units. So it means it's being given at 5 milli-international units, 5 milli units per minute rather. So you just simply divide 15 divided by 5. Then what drugs are indicated by X at 4 hours? So here, usually we give pethidine as well as an antiemetic. Then what abnormalities are shown on the pathograph at t equals 10? So we come to t equals 10, where this person dilated to about 8 centimeter, but remained at 8 centimeter. The descent still is so poor, so this person didn't descend, and they are still remaining at 2 a descent of 2. Then we can see that there is meconium that is present, grade 2 meconium, and there is molding that is present, 3+ molding. And we can even see that the fetus here, the heart rate has begun to actually drop below the normal. The normal should be between these two dark lines. So here it's dropped between this lower dark line. So there is fetal bradycardia that's happening. Even the contractions are still present. So this child is actually in fetal distress. So how do I know this? Is because the fetal heart rate has decreased, and of course meconium has passed. And the molding may show that there is obstructed labor, so this child may need a cesarean section. I really do hope you understand what is going on in this pathograph. Then station 7, inactive management of third stage of labor. What is the drug of choice? The natural equivalent of the drug acts on what 2 parts of the body? So take your time to pause this video and scream the answer towards your screen. And here comes the answer. So the drug of choice is of course oxytocin or syntocinon. And oxytocin usually works on 2 parts. It works on the fundus of a pregnant uterus, so it should be pregnant. It works on the fundus of a pregnant uterus to cause uterine contractions during labor. It also causes the contraction of myoepithelial cells, which enhances the ejection of milk. Moving on to station 8, so you have a 39-year-old that is admitted to the ward, at 24 weeks in her first pregnancy. She was admitted with a blood pressure of 145/90 and proteinuria 1+. She received no treatment since admission. Blood tests performed on admission reveal the following. So hemoglobin 13.1, platelets 152, creatinine 120, ALT 45, ALP 210, bilirubin 9, albumin 25, uric acid 0.59. The midwife reports that the 24-hour protein is 6.2. What are the differential diagnosis and why? What other history would you obtain? What other investigations would you arrange? What complication may arise? So take your time to actually think through this question and give your answer in the next slide. So here comes the answer. So this may actually be severe preeclampsia. Why? Because first of all, this woman has a gestational week that is greater than 20 weeks. So she's at 24 weeks. Her blood pressure is greater than 140 millimeters of mercury, though it's just been taken once and they didn't do a repeat after 4 to 6 hours. She also has features of hemoconcentration, which is an HB of 13.1, though in retrospect, actually looking at this other reason of hemoconcentration, maybe there should have been a typo, but this shouldn't have been there. Then there is a high level of uric acid. There is a high level of creatinine, which may also back the hemoconcentration. There are elevated liver enzymes, like for example, ALT is elevated. So there may be some hepatic involvement. All these features may be pointing towards severe preeclampsia. Or it could be chronic hypertension with superimposed preeclampsia, because there is no booking pressure and they haven't given us a history of whether this woman did or did not have hypertension prior to the pregnancy. So the other questions that you would actually ask on your history are whether she's had hypertension before, whether there's a family history of hypertension, whether she has given birth to family history of twins, because she could be carrying twins. If she has had exaggerated symptoms of pregnancy like hyperemesis gravidarum, and even symptoms pertaining to UTIs. Then other investigations that I would order for: imaging, so ultrasound for the fetal viability. You would also estimate the fetal weight, amniotic fluid indices. Then you also order a series of blood tests. So full blood count to be checking your hemoglobin, platelets, your liver function test, your serum albumin, bilirubin, and prothrombin time. Your renal function test to be checking for serum urea, electrolytes, and creatinine. You also do a urinalysis. Then what complications may arise? So maternal complications include eclampsia, which may progress to seizures, HELP syndrome, which simply stands for hemolysis, elevated liver enzymes, and low platelets. Preterm labor, abruptio placenta, disseminated intravascular coagulation, pulmonary edema, renal failure, maternal death, even high risk of surgical intervention or operative deliveries. Then fetal complications include intrauterine death and prematurity. Then station 9, what is the mechanism of action of this drug? Mention 2 indications for its use. State 3 ways of detecting possible toxicity of this drug during administration. You find a patient is exhibiting these features while on treatment. What would be your action? The condition of the patient does not improve regardless of your intervention. What drug can you administer to such a patient? So take your time, pause the video if you so may, but here comes the answer. So obviously this is magnesium sulfate, and magnesium sulfate is going to be working by causing cerebral vasodilatation. It also acts by acting as a membrane stabilizer, so it's going to be preventing seizures. It can also act as a competitive inhibitor of calcium, which is why it can also be used as a uterine tocolytic to relax the uterus. So mention 2 indications for its use. So it may be used in hypertensive disorders of pregnancy like severe preeclampsia and eclampsia. It may be used in tocolysis of the uterus. So a tocolytic is a drug that relaxes the uterus. Then of course 3 ways in which you detect toxicity. So you check for the urine output. It's usually less than 30 mils per hour. The respiratory rate will be depressed, less than 12 breaths per minute. And of course, they will be diminished or even absent deep tendon reflexes such as the knee jerk. So when you find these things, you should stop the magnesium infusion, or you should stop giving the magnesium sulfate. And if the patient doesn't improve, give calcium gluconate, 1 gram in 10 minutes. The last and indeed the final station, mention 2 major indications of this drug, list 2 other alternative drugs you can use and mention the indication for its use, name 3 conditions in which these alternative drugs are contraindicated, give 2 reasons why they are contraindicated, what are the possible complications that may arise from the use of the drug shown on the picture. So take your time to pause the video, but here comes the answer. So obviously this is oxytocin as already labeled on the bottles. So it's used in induction as well as augmentation of labor. It's used in the management of postpartum hemorrhage. It's also used in the active management of the 3rd stage of labor. And 2 alternative drugs that you could use egometrin or methadone for postpartum hemorrhage management, and then misoprostol can also be used for induction of labor. Then 3 contraindications for the alternative drugs: avoid them in patients with vascular disease, avoid them in patients with severe cardiac disease, with severe hypertension, as well as eclampsia. Reason being, it's because they cause sustained contractions, and they also cause alpha receptor activity to be increased, so they increase peripheral vascular resistance. Then the possible complications include uterine rupture from uterine overstimulation as well as fetal distress. Thank you for spending your time to listen to this episode on the Bazooka. If you really enjoyed the video, drop a like, drop a comment as well, hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. See you in the next video, and I hope these videos are helping you prepare for your exams. If they are, then comment in the section below. But for now, to Zambia and beyond,